So very excited to welcome on Libby Powell. Now, Libby is a PGY2 critical care pharmacy resident at the UNC Medical Center. Libby, welcome. How are you doing today?
I'm great. Thank you so much for having me. I'm very excited for our talk today.
The pleasure's mine. Now, first things first, though, I always joke, I don't necessarily want a boat, right? You want a friend with a boat, but you are actually one step above that. You are a friend that knows how to drive a boat because you have your boating license. So, how long have you had it?
I think I got it actually when I was like 18 or something. It was the best $30 I've ever spent in my life.
Literally, it's like it's $30 and done. That's it. You're just a lifetime boat license
I think so.
as a
That's
boat.
that's the impression I'm under. So fingers crossed.
Oh no. Oh no. Don't if we're putting Libby on blast, she's great. She definitely is renewing everything.
Hey,
All right,
I've successfully driven a boat 2 times in my life. So
only two. All right, describe the boat. Speed, pontoon.
it
I'm
was a
guessing not a
speedboat.
yacht, but you could surprise us.
Oh
Speed.
yes, it was a speedboat. Yes, yes.
Okay. You're past that. Was this something where were you supposed to be taking the speedboat out?
My friend's dad was there to
Oh,
chaperone me,
okay.
I
Yeah.
will
Okay.
say. So I
Okay.
had backup just in case, but I didn't run into anything. So like we're gonna take that as a win. So
That feels like a win. Were you able to park it? That's the hardest part is getting it
I,
back
I
into
have
the
not
dock.
parked the boat. That's so
Yeah, that's
we'll be stuck out in a little bit, but it's okay.
yeah, that is the next level thing. But again, it's even better to be like, oh, here, I did all the fun stuff. You can take it out and do all the things.
Oh yeah.
Um, Okay, so very, very excited for our talk today because in the treatment of aneurysmal subarachnoid patients, it feels like our pharmacologic therapies are really, really limited, except one. And this one therapy, once you start, you do not Nemo stop. So, Libby, take it away.
Awesome. Thank you so much. So I'm very excited to talk to you all about. It's a topic that I find super fascinating, and that is the use of nimodipine for aneurysmal subarachnoid hemorrhage, a segment I would like to call Finding the Benefit of Nemo. If you've ever met me, you know that I had to slide that joke in there. But before I begin, a note just for the ease of your ears and for my pronunciation. I will refer to aneurysmal subarachnoid hemorrhage as simply subarachnoid hemorrhage for the duration of this podcast. And in that same vein, let's spell out some terms that I'll be using throughout the podcast and go through some of the background. So what is a subarachnoid hemorrhage? So it's whenever you have bleeding in the space between the brain and the membrane that surrounds and protects it. So the subarachnoid space. Most often, this happens when an aneurysm or a bulge or ballooning of a vessel, and that comes from the vessel weakening, burst. So this unsecured vessel pops, and then we see the effects from that. Vasospasm, or an acute narrowing of a vessel, is a common sequelae of subarachnoid hemorrhage. So, why do we care? Why is this important? So, vasospasms can lead to DCI or delayed cerebral ischemia. So, DCI may have multiple mechanisms. That includes blood brain barrier disruption, microthrombosis, cortical spreading depolarization, and ischemia, and failure of cerebral autoregulation. As discussed with Dr. Farouk, I really like the way that she put it that the blood almost becomes toxic to the brain and that the arteries around it become narrowed, which then leads to have impacted blood flow, and this can lead to infarcts. So then this can all lead to permanent neurologic deficits. So we can see these complications typically around like day 4-ish, and then we can see a peak around day 7 to 10. And these can go up to day like 20 to 40. So this is a continuous and progressive infarct that can be quite significant and can lead to pretty permanent neurologic deficits. It is important to note that these patients are not just a one problem kind of patient. We have to watch things like brain swelling, electrolyte abnormalities, in particular our sodium, blood pressure variations, and many, many other things. So now thinking about nimodipine. So where did nimodipine come from? What put it on the map in neurocritical care? So we have two landmark trials that kind of put it on the map and really changed practice. So the first trial was done in 1983, which was a multi-institutional prospective double-blind trial that looked at whether treatment with nimodipine within 96 hours of a subarachnoid hemorrhage would prevent or reduce the severity of ischemic neurologic deficits. So they concluded that nimodipine should be given to patients after a subarachnoid hemorrhage in order to reduce the occurrence or of severe neurologic deficits from cerebral arteriospasms. So this trial kind of put nimodipine on the map. I will say there were some caveats when this was done. So it was done in 1983. So classifications and just kind of treatments and things how we do now were different from how we practice now. And they also did have a unique dosing regimen. A really practice change was really seen after a 1989 trial that was done that focused more on infarction and functional outcomes compared to that 1983 trial that really kind of focused on the angiographic evidence. So this trial, the 1989 trial, was a European trial that looked at the use of nimodipine with 3 months follow-up to determine the efficacy in reducing cerebral infarction and poor outcomes that included death and severe disability. The authors concluded that nimodipine was well tolerated, reduces cerebral infarction, and improves outcomes, and this was statistically significant, and these positive effects were sustained through that follow-up. A big positive of this trial is that it really hit on the functional outcomes and really kind of the DCI component, and not just the vasospasm that the 1983 trial kind of really focused on. So this kind of led us to this leads us to what nimodipine really does. So how does it work? So nimodipine is used for vasospasm seen from a subarachnoid hemorrhage, right? Like that's the magic answer. False. So it does not fix vasospasms. It helps really prevent DCI or that delayed cerebral ischemia. So as I mentioned before, this is a progressive process. So after a bleed, the cerebral damage has been done. That damage is done. Nimodipine's niche is really to help prevent more damage or that like next damage after the bleed. So now kind of thinking about what do guidelines say about the use of nimodipine in this patient population. So the American Heart Association, American Stroke Association has a grade 1 recommendation saying patients with subarachnoid hemorrhage, early initiation of enteral nimodipine is beneficial in preventing DCI and improving functional outcomes. In a similar vein, in the Neurocritical Care Society guidelines, they have a strong recommendation with moderate quality of evidence that reads, we recommend the administration of oral nimodipine in patients to reduce DCI and cerebral infarction and to improve functional outcomes. So both of these really point at starting as early as possible with this oral nimodipine. And with that, we're really thinking whenever we have enteral access is when we're thinking about starting our oral nimodipine. So nimodipine is a DHP calcium channel blocker. So that which its only use is really in the setting of subarachnoid hemorrhage. And it's not only a calcium channel blocker, but it's the most lipophilic calcium channel blocker. So one of the proposed mechanisms is nimodipine reduces the narrowing of vessels that leads to better blood flow to the brain. So nimodipine is highly protein bound. It has really good brain penetration and kind of seems to have more blocking of extracellular calcium than intracellular calcium. And it seems to favor cerebral vessels, which in this patient population is really what we're kind of shooting for, what we want. Our typical dosing is what we saw used in the 1989 trial, which is oral nimodipine, 60 milligrams every 4 hours, my apologies, for 21 days. There it is. A limiting factor is hypotension that these patients can experience with nimodipine. So a common strategy to get around this is to reduce the dose to a 30 milligram Q2 hour regimen. Now, there's not really robust data telling us that we should be doing that. Guidance also suggests the use of vasopressors could be a strategy to allow patients to continue with the kind of the full dosing of nimodipine at that typical dose who may be experiencing that hypotension. There is no consensus on whether one of these practices better or than the other or provides the same potential benefit as our normal dosing. Okay, cool. So we have this medication. We know it can work and we know it does work and can provide our patients with functional benefit. There are, however, some practical considerations that are quickly forgotten, and that's really kind of starting with how do we give this drug. So, nimodipine is available as an oral solution and capsules in the US. In Canada and Europe, there are other forms, including IV, but these are not available for use in the United States. So, especially in our critical care setting, many of our patients will be intubated, and we need to consider administration of nimodipine. So, with an NG tube or a gastric tube, you can either use the oral solution or you can actually take the solution out of the capsule and give it via the gastric tube. If your patient's able to swallow, either the solution or capsules can be given. Maybe it's a me thing, but I kind of always thought of nimodipine as a pretty benign drug. And this will sound familiar to our pharmacist population, but you guessed it, it is a CYP3A4 substrate. It's actually interesting that with the different formulations, there are specific contraindications that we need to be aware of. So, with the capsules, it is contraindicated with concomitant CYP3A4 inhibitors. Oral solutions, there are actually no contraindications. And then the tablets, which are used in Canada, we need to contraindicated use in with phenobarbital, phenytoin, and some of our anti-seizure medications. So these factors may point us to using one formulation over the other that may be available to us. And not only do we need to think about the actual formulation, but we do need to think about some of the pharmacokinetics of nimodipine. So, nimodipine is highly protein bound, like I mentioned before, and we know that food disrupts the absorption of it and can cause some pretty significant variation in absorption. With this variability in mind, it is important to note that we should be administering it at least 1 hour before or 2 hours after meals, something that really might fall through the cracks in terms of our dosing in our ICUs. And something that you would need to think about is if a patient were on continuous tube feeds. Should we be stopping it? Should we be clamping the tube feeds for administration? There's not really any data to tell us one way or another in this patient population. And so that kind of I'm starting to sound like a little bit of a broken record, right? We don't really have that data. And that's really kind of the story with nimodipine. We have data that it works, it's relatively well tolerated, and it's an older drug. But even with it being pretty standard of practice at this point, we do have a lot of unanswered questions, especially in the setting of our critically ill patients who most likely do not just have one disease state going on and that we are treating. So, some of the lingering questions are things like in our hypotensive patients, is there a superior mitigation strategy? Is it better to have the patients on, quote, full or complete dosing with maybe some support from a pressor? Or does a smaller dose give us the same benefit? So, that 30 milligrams Q2. Or are either of these options harmful? Do we need the full 21 days for treatment? We know this is a progressive disease state and we're trying to prevent further damage. But what if patients only receive nimodipine during that peak window of like 7 to 10 days? Would that give us the same benefit? And also, what if we miss a few doses? Does the clock start over? Should the clock start over in terms of our duration? So, nimodipine has a big role in the management of patients that suffer from subarachnoid hemorrhages. We know it works, it gives patients functional benefits, and now and in the future, we need to think about how we can optimize this nimodipine. But for now, with a little twist of Dory's famous line, just keep dosing.
You're dominating me in amazing puns today. You are definitely where you belong. Um, so you mentioned a lot of, and by the way, 30 milligrams giving something every 2 hours is just shout out to the nurses out there. That's
Oh,
absolutely
definitely.
crazy. Now, in a lot of these patients, or especially our most sick ones, they're going to be mechanically ventilated, enteral only. So is there any data to support? You mentioned we have the solution and the gel caps that we can give per tube. Some people even compound it, right? But we'll focus on
Mhm.
kind of solution and gel caps. There's pros and cons to both, right? Solution's expensive, gel caps are less expensive. So is there any data to say that we should be using one or the other specifically in those or in patients that you're giving per tube, I guess,
Mhm.
ventilated, G tube or otherwise?
Yeah, so like I mentioned, so and kind of what you've alluded to is if you have an intubated patient or just a patient with a gastric tube, you can either use the oral solution or you can take the solution out of those gel caps and administer it through the tube. In terms of like if there is one better than the other, there was actually a retrospective multi-center observational cohort study that was conducted in 21 hospitals across North America that showed a few things. One, oral nimodipine, the liquid product, was independently associated with a higher prevalence of diarrhea compared to the other administration techniques or formulations. Bedside withdrawal of that liquid from the nimodipine capsules, so taking it out of those gel capsules prior to administration, was significantly associated with higher prevalence of nimodipine dose reduction or discontinuation secondary to hypotension, which is pretty interesting. And that tablet crushing and bedside withdrawal from the gel capsules prior to administration were associated with increased odds of delayed cerebral ischemia, so that DCI that we're trying to prevent. So, really, overall, from the study, we start to see data that these formulations and administrations may not be equivalent. Other than that, we don't really have a ton of data that really dive into these differences. And kind of following a similar theme, we just need more data in this setting to be confident on if one formulation is superior in our ventilated patients in particular.
But at least what we have now, and it would make sense mechanistically, right? Like the product that you think you're more reliably absorbing, you
Mhm.
might have more side effects from it, right? The diarrhea. And then on
Definitely.
the other side, the product that you may not be absorbing everything, getting all the action. Whenever I think of drawing the liquid out of those gel caps in the same
Yeah.
thing that I think of as nurses giving an IV push of 5 minutes. It's just
Yeah.
not happening. It's
No.
not like so I don't so I think my big takeaway is if you have any pull with your awesome pharmacy purchasers, try to get some solution. I love that. Got a shout out. That's a who's who of neurocritical care pharmacists in this pharmacotherapy study. So awesome of you to shout this out. And even more great being able to talk about a topic like this and still bring us tips, tricks, and pearls on something where we're talking about a study that was published long before you were born, 1983. So awesome topic. Even better having you on and getting to learn from your expertise, research, and all those things. So appreciate your critical care clinical pearl today, Libby.
Thanks so much, Nick. Thanks for having me. And remember, the solution may be the solution.